So thanks for having me. And, it's very humbling to be sitting with three of you guys and trying to present a talk on endoscopic anatomy. But anyway, I'll give it a go. So that's basically been my path. I did some, a couple of years in the lab, and then I've spent almost 3 years with Juan in combination with the lab time and a clinical fellowship, and also did a vascular fellowship with Gary, and currently sort of trying to build a career in expanded endonasal work, pituitary and vascular work. So just going to cover the sort of key anatomical aspects and also add some illustrative cases, going back to a lot of the Pittsburgh papers that I was involved with, as well as what the group at UPMC produced over the years, and what I have found quite useful in my first year, really starting this practice, some of the basic concepts, and covering, this is the sort of spectrum of stuff that I'll try and get through in this period of time. So anyone sort of starting out in endoscopic surgery, the two things you get told, you really want to appreciate and understand the endoscopic anatomy of the ICA, as well as understand the sixth nerve, because they always get in your way, or they're in your way, and you have to really know how to handle. So here, this is the cavernous sinus paper that that came out of UPMC, and I was part of that manuscript. And really, we're looking at the segments of the ICA here. Often, this segment is often referred to as the paraclival ICA. We define the cavernous ICA starting here, going to your posterior genu, and then you have your horizontal parasellar ICA continuing on as your anterior genu. And very importantly, from an endoscopic perspective, you define what we used to think after clinoidectomy as the sort of clinoidal ICA or the carotid cave. From an endoscopic perspective, you're looking at the ICA between the carotico-clinoidal ring, which is your proximal ring, and your distal ring. And this is your paraclinoidal ICA. And it's quite important to understand the orientation of this ICA, particularly if you're trying to uncover it for endoscopic approaches, because it's not a straight vessel here. It loops medially, and there is a chance of injuring it if you're using kerosene or trying to expose it in the wrong way. So this is the sort of understanding about the ICA anatomy. We will talk about the cavernous sinus and each one of these individual nerves and the compartments. This is obviously our midclavus, and this is the basisphenoid. So I looked back on this paper, which was in 2012 from Paul and Juan, really, highly relevant. I started my practice and saw the number of adenomas which haven't gone into remission, functional remission, because people haven't gone lateral enough with their exposure and done a proper middle clinoidectomy, and therefore get to the lateral aspect of the adenoma. So very much going, for the general audience listening into the talk, for most pituitary adenomas, you want to see the lower aspect here, where you're seeing just the beginning of the cavernous sinus, and then where there is potential invasion of the retrogenu or the medial compartment, you want to uncover or do the middle clinoidectomy, and that involves uncovering your paraclinoidal ICA. And the basic steps, as it were, which are really well outlined in the paper, and I learned from under Juan's mentorship, is really sort of going across inferiorly, finding a safe plane with the cavernous sinus, creating two fracture points, and then out fracturing after eggshelling, rather than try to kerosene it out and risk injury. And you can see the prominence here, which we refer to as the middle clinoid. So this is a case, very beginning of my time here. And this was a young woman who hadn't gone into biochemical remission after a previous excision of an acromegaly lesion. I think she even had a PET scan in Cambridge, and you can see a clear focus of the disease on the right side. And these are post-resection images. And her 3-month hormonal panel is now normal. This is a short video. I don't know if it will play well, but I can try. So it was clear from the first sort of surgery that none of this part had been exposed. So we did a more of a expanded approach, going up to the parasellar ICA, Dopplering it out. This was a redo case, so took my time with it a little bit more. And just by extending the corridor here more laterally and doing a wide sort of a sphenoidotomy, there was all this tumor that was tucked in that we were able to remove. And And, you know, I didn't think there was true sort of medial or a retrogenu compartment invasion, and you could see a fairly clear compartment there, and she went into remission on the latest test. So now sort of talking specifically about the cavernous sinus and the compartments, this was a paper that we did some time ago, and we presented this at the North American Skull-Based Society meeting in Florida. So starting with the commonest compartment where we work is our retrogenu compartment, or the medial compartment. And the important thing to understand, and this sort of also blends in with the concept of pituitary transposition, a transcavernous pituitary transposition, because it's again that appreciation of that ring, an appreciation of the fact that you have two layers of dura here, a periosteal layer that blends in with the floor, and then you have the meningeal layer, which is going on the medial side, and you're really finding the plane in between the two at the floor of the sella, and then dividing the ring and sort of working your way back up to, and I'll show more specific pictures from posterior clinoidectomy aspect. And again, to access this compartment, you need a full middle clinoidectomy because you want to uncover this area, and then you're looking into the compartment. Here you see top of the posterior clinoid, and this is a really nice important landmark here. That's the interclinoidal ligament. That is a good landmark for working out. On the medial side, you have the clinoidal, triangle, and on the lateral side is the oculomotor nerve. And again, as in the paper, in the cavernous sinus paper, we think of third nerve more posteriorly in this compartment as being more robust, whereas as you get more anterior in that compartment, the nerve is more naked and perhaps more vulnerable to injury. So that's that's the compartment when we talk about the retrogenu compartment. And again, this is another one of the cases, I think sort of my first or second month in my job, where you see a chap presenting with full cavernous sinus syndrome, apoplexy, and post resection, we were able to get a nice clearance of the disease. I'll run this video very fast forward, again, trying to expand. Same thing around sort of doing a more expanded approach, and then trying to get into the right next to the carotid and try and clean this out fully rather than leaving any residual disease behind. Again, it goes down to the principle of doing a nice ICA exposure, doing middle clinoidectomy, and working in the compartment under direct vision. And this trick, obviously, with the gel foam is massively helpful while working in this compartment, and stops and makes things much more efficient. This is one of the other cases. Now here, for example, this chap presented with unstable, with visual dysfunction. And again, here, I did leave a fibrotic cuff on the third nerve more anteriorly, where I was more concerned about potential injury. And he had a good recovery from his visual issues. So what about other compartments? I'm talking about inferior compartment here now. So again, we really, when we are talking about the cavernous sinus compartments, we are talking about it in terms of the division is based on the ICA. So this is the compartment that's sitting below the horizontal ICA. And we are looking at, and it's bounded by the horizontal ICA above, the short vertical at the back. And the main nerve here that is at risk, or that we worry about, is obviously the sixth nerve, the distal cavernous segment of the sixth nerve. And the sympathetic chain is usually following a sort of a straight line here. So when we are thinking about this compartment, we are always thinking about this ICA loop, the horizontal ICA, and the sixth nerve. And again, sixth nerve keeps cropping up everywhere in endoscopic surgery. So now when we are thinking about the posterior compartment, we think about the boundaries of this posterior compartment of the cavernous sinus. More inferiorly is again the sixth nerve, more specifically the so-called Gulfar segment, or the suprapetrous segment, just above the petrous apex. And you see that dural fold here, which is your petrous sphenoidal, or the Gruber's ligament. And in this compartment, as one would expect, you have branches of the meningo-hypophyseal trunk that vascularize this compartment. And here's an example of a tumor that has invaded, or that has presence of disease both in the inferior compartment as well as in the posterior compartment. In terms of the individual nuances of approaching these compartments, I'll leave it to the more expert and experienced people in the group later on, but this is just sort of covering the anatomy. I haven't particularly gone into the lateral compartment. I think there the surgery is usually, there's a much higher risk of causing issues with the cranial nerve function, but there will be pictures further on in the presentation where we will be able to see that. So now sort of moving more to a suprasellar approach. When we are thinking about suprasellar approach, this was one of the papers that I did while I was in the lab at UPMC. And this was more specifically with respect to really tuberculum sella meningiomas rather than anything else, but it really helped me massively in my practice later on and in understanding the difference between how to tailor your suprasellar exposure. So going through the osseous anatomy here, we are obviously thinking this is looking at the sphenoid sinus side on. So here is our tuberculum, the medial ossia with optic strut, anterior root, and optic strut is basically your posterior root. And then this structure here is the limbus sphenoidale, with the space between the limbus and the tuberculum being referred to as the chiasmatic sulcus. So, and these, here we've put in yellow sort of structures to denote optic nerve, V2, and the Vidian nerve, and this is maxillary strut. So the idea in this paper was to look at optic canal more specifically from the point of view of if one was doing tuberculum sella meningioma, which is invading the optic canal, how could we safely address that? How could we safely open that? And what is the osseous and the dural correlate of the optic canal? So again, this is all the work in the lab at the UPMC, and we can see that this is a transcranial perspective. We're looking at the limbus dura, the falciform ligament, and the idea was to identify the point where, coming from an endonasal perspective, you can detach the falciform ligament and then cut along the optic sheath and lower aspect of the nerve, slightly upper aspect of the optic nerve in order to enter the optic canal. So in terms of landmarks, again, for the sort of more general audience, we have the clinoidal ischia here, lateral ossia. This is the limbus, an important dural fold that you see all the time when you're performing this sort of approach or resection, and chiasmatic sulcus, and then we are looking at the tuberculum and the superior intercavernous sinus there. And this was sort of definition of osseous optic canal, or what we considered optic canal, which was really defined by the lateral ossia, with this segment representing what transcranially we would consider the preforaminal segment, or the segment that is roofed by the falciform ligament. And if one was doing this approach for a tuberculum sella meningioma, again, the idea was to start with opening the dura over the sella, working upwards, and this is the point you're detaching the falciform ligament and then going along. And this, the number 4 cut really is tailored based on how far or how extensive the invasion is into the canal. And the number 2 cut is posteriorly along the diaphragm, and 3 is more towards the distal ring, again, to mobilize the ICA. And these are sort of the dural cuts from there. One of the things that JFM Juan emphasized sort of while I was training with him, and again, subsequently that I have found in my practice, is approaching craniopharyngiomas versus tuberculum meningiomas and tailoring your exposure. So most times, as we all know, majority of the work for the craniopharyngioma is going to be through the chiasmatic sulcus and the area above the sella, with some exposure of the limbus dura. We don't necessarily need to, not limbus planum dura, we don't necessarily need to open all that dura. Whereas for a tuberculum sella meningioma, depending upon the anterior extent of your of the lesion, you have to tailor that opening in the planum dura. So in effect, there's no point sort of opening the dura up here while trying to do a cranial unless the lesion dictates that. And this is showing the versatility. This was one of my cases towards the end of my fellowship at Stanford, one of the so-called graduation cases. And this is sort of demonstrating the utility of doing that middle clinoidectomy, again, with a standard suprasellar exposure for a relatively small tuberculum sella meningioma. And that, again, is finding the plane with the cavernous sinus and then trying to out-fracture the whole thing. Now, this piece of bone, when it comes out, does have a nice, I'll just fast forward it, does have a nice bit of middle clinoid that comes out right there. And that And this bit of the exposure, again, from a technical perspective, we do it right at the end of the exposure when we've done the majority of the suprasellar drilling. In terms of the final exposure, just as a close-up, again, pausing that, this is for tuberculum cell meningioma, so you can see the exposure has been taken further along into the planum. And again, this is the level of the intercavernous sinus, and here's that nice fold, the dural fold, the limbus sphenoidale that is always present reassuringly. And this is a sort of end resection view. One of the important nuances, obviously, in these suprasellar approaches is to preserve the superior hypophyseal perforatus at all time, which comes off the medial aspect of your supraclinoidal ICA. Here, the optics are not as good. This was a bigger meningioma where obviously the exposure is taken much more forward. It was very, very stuck to the right optic nerve, and really all I did was to progressively thin that down on the right optic nerve, leaving a cuff. So one of the points that JFM and Paul and all of you have talked about in the past is preserving the perforatus, and this is a nice close-up shot of the superior hypophyseal perforatus, and it's vitally important in these operations, in the suprasellar exposures, to preserve them to optimize the visual outcomes. And this was another case within sort of starting in the first month, a young chap with suprasellar tumor who presented with this lesion with acute sort of visual dysfunction. And here are my sort of tentative attempts to try and preserve those perforators, but just trying to demonstrate that I learned something from the fellowship. Here is Dr. JFM now in another operation. Now we're doing a craniopharyngioma here and trying to maneuver that bit of craniopharyngioma along that perforator. So it's far too easy to try and think you can just coagulate that and take that, but it really is worth it and the effort to try and preserve that superior hypophyseal perforator that he does very well by using that plate dissector. So going on to next aspect of the talk, we talk a little bit about the upper clivus and the retroinfundibular area, sort of moving south. Here I've really focused on the transcavernous transposition rather than the various types of transposition, which I presume will be covered later on in the conference. But again, this is a big contribution from UPMC by Juan and Paul. And here we are, similar to what we discussed before. This is going in between the layer of the periosteal and meningeal dura and safely controlling the inferior hypophyseal and getting access to the dorsum sella and the posterior clinoids for removal. So this is from my lab dissection almost 4 or 5 years ago now. And again, demonstrating those steps. Here's your inferior hypophyseal artery that obviously you take in a more proximal location with this sort of transposition technique. Talking again about the carotico-clinoidal ring. So taking this ring, the proximal ring is the easiest way I find in terms of thinking about it. It's coming from the anterior clinoid, attaching to the medial wall of the gland, and removal of this ligament really does allow you, and sort of what I've adopted is the use, again, having watched JFM and Paul, use McElveen knives in order to detach this ring. You feel much safer, and then gives you the access, more rostral exposure. And I'll show a video. This is a video that we showed at the NSBS. That's JFM's work here and we published this in Neurosurgery Focus. This is a pediatric chordoma case where you see that incision being made with use of Doppler, finding that layer between the periosteal and meningeal layer, and then you get that gush of fluid from the blood from the cavernous sinus, and then you're working your way. That's the McElveen knife doing that cut, and then you're working your way backwards towards the inferior hypophyseal, taking it in a controlled fashion. And the beauty is that you don't have to do the same thing on both sides as demonstrated here. Then on the other side, you can do a subsellar extradural approach rather than trying to do bilateral transcavernous transposition. So you can tailor it according to what you need, and that's the expected gush of again, blood from the cavernous sinus, because we know the posterior clinoid is in the roof of the cavernous sinus. So
Kumar, 2 minutes.
Now, going to move down to the mid-clivus. 2 more minutes? Okay.
Yes.
I think what I'll do is I will go down. So I'll just show the pictures basically. So this is, just demonstrating, just working south towards mid-clival exposure. And we're all familiar with this anatomy. You have the basilar trunk. You're really opening up into the prepontine cistern. And again, you're looking at that back view along the sixth nerve. And this is where one sort of goes back to the sixth nerve again in terms of the cisternal segment and then the interdural segment going on to the carotid and the cavernous segment. We can skip this because I'll just carry on with the Foramen Lacerum aspect about the Foramen Lacerum and the inferior clivus, and finish up with understanding the lacerum is important because it's the junction between your mid and the lower clivus, between the coronal and the sagittal work. And we define this as a confluence between these three fissure lines, as we can see, pterygosphenoidal, petrosphenoidal, and petroclival fissure. And the key thing that sort of is worth highlighting is when we are doing a sublacerum axis, so if we go down here, when we are trying to work towards the petroclival fissure in that inferior compartment, trying to widen that exposure inferior laterally, it's the division of this fissure line that is important, finding that, following that backwards, using the Vidian as a landmark, and you have about 45 to a 30-degree angle, and that allows you to mobilize the eustachian tube down south. So that you get access inferiorly and laterally towards the petroclival fissure. So that's when is that useful? Well, one of the things that I want to finish up with is